I'm Chris Hathaway. I am a physical therapist at the University of Michigan CF Center. And I've been working in CF for about 15 years or so. So today I wanted to touch on the role of physiotherapy or physical therapy in cystic fibrosis, and really looking at instructions to teens, but also to our patients. So the role of CF, or PT in CF, is kind of multifactorial. We in the US focus a lot, along with our respiratory therapy colleagues, on instruction and airway clearance techniques. In addition, we look at posture, muscle function, exercise capacity, and really developing individualized exercise prescription for aerobic resistance and flexibility exercises. That's becoming even more important as we move into this era of highly effective modulators. We also do still screen for vestibular deficits, as well as urinary bowel incontinence. But probably our most important role is that we educate caregivers and our patients on everything that we do. That is, it's great that we know all this, but it's more important that our families know it. We here at the University of Michigan, we see our patients minimally, in best case scenario, annually in the outpatient clinic. And again, that primary role in the clinic is education of patients and parents. Very rarely am I doing a treatment with them when they're coming in. I'm teaching them how to do their treatments themselves at home. And then working with the patients to determine what goals they have, what do they want to be able to do. We do see patients while they're admitted in the hospital, and that's where our treatments become a little bit more important. We'll see those patients twice a day to assist us with their airway clearance, along with respiratory therapy and our nursing colleagues. But we'll also bring complete exercises, assessment and exercises when they're admitted. Our admissions tend to last anywhere from 1 to 3 weeks. During that period, we've kind of got them in a captured state that we can do a lot of education. We can start to do some exercise. We can start to show them that they can do some of these things. And we'll continue to provide that education. So why do we do airway clearance? The principles are really we're loosening those thick secretions from the airways. We're mobilizing mucus from those distal airways to the proximal airways. And then we're going to clear those secretions utilizing the huff or the cough. The goal there is, as we can clear those airways, we're hopefully going to help reduce the inflammation, going to hopefully reduce infection over time. For my families, when I teach them airway clearance, I tell them it is going to be not a super rewarding thing. You're not always going to notice a big difference in how your child acts, how they behave, things like that. But over time, it's one of the most important things that we can do for them. It's one of the things that doesn't take much as far as medications and effort. Well, it takes a lot of effort, but it doesn't take a lot of resources. But it's probably one of the most beneficial things that we can do, that we can introduce for families. We have lots of choices to do airway clearance. We have your O.P devices, so your oscillatory positive expiratory pressure devices. That is your Aerobica, your Acapella, and your CariPets. There's a few others out on the market as well. It just depends what's available in the area. There's also your positive expiratory pressure devices, so your PEP devices, and then the VEST, or the high frequency chest wall oscillation. Devices are great, but they don't have to be everything by any means. If you don't have them available, there's lots of other options. For our O.P devices, just for time, I'm not going to go into all of the technique, but what we're doing is ideally exhaling out through that device twice as long as your holder, about ideally for about a count of 10. And what that's doing is helping to support or loosen those secretions. The goal then is that we are always, no matter what kind of airway clearance we're doing, we're going to follow it up with that or that expiratory technique to clear the secretions. Another oscillatory device that you can do is what's called bubble PEP. The beauty of bubble PEP is it is a simple, easy, cheap way for families to do airway clearance. They can set this up at home with a little bit of education. What we do is we cut a section of tubing about 35 to 40 centimeters in length, and we fill a container with water to 475 milliliters. In the hospital, we'll use a saline bottle is what we use. At home, we've had parents use milk jugs, whatever kind of carton that they can find, so we can get that amount of water in. We put a couple of drops of detergent. You can put food coloring, you can put whatever you want in there. My one caveat to the detergent is if you're doing it with a really young kiddo who doesn't understand yet that they only need to blow out, that if there's any risk of them sucking in, don't put soap in the end. They'll probably only do it once, but you want to avoid that if you can. And then you have them take a deep breath without the tube in their mouth, and then hold it for 2 to 3 seconds and blow out. That blowing out through the tube creates bubbles in the water, motivates them because of that detergent to make those bubbles rise higher and higher and higher. It's a great way. I've started kids as young as 3 years old doing this bubble bath so that we can start to introduce something different for them. We do that 10 times, and that's considered 1 cycle. If they're old enough, we'll do that cycle cough to clear the secretions, and then let them come back down to their baseline breathing, and then we'll start another cycle. Like I said, this is something you can do. We do use it in the hospital. We have kids do it at home, and we've had a lot of our patients that don't get great results with vest or with manual percussion or any of the other devices that do this and bring gases. So everything's going to be a little bit different. Next one is high frequency chest wall oscillation. And as you know, it's an inflatable vest, jacket, or wrap. Chest wall is compressed, and the airway oscillates. Treatment time is about 20 to 30 minutes. Its effect on the airway is similar to many cutoffs. People get really excited about the vest, and the vest is a great technique, but it's only one technique, and it's only one name. And if you're using the vest, occasionally it's not as effective. You have to have other airway clearance techniques to go with it. I will also say, in the US especially, the vest has made some of our individuals a little bit less active in their participation of airway clearance, especially some of my teenage kids. They'll slap that vest on, they'll go back and lay in bed and take a nap. It's not the way it's intended to be done, and it's not nearly as effective. And then we get into some of the device-free therapies. So manual percussion and vibration, which for our patients really under the age of 2 is our primary technique that we use. We've got active cycles of breathing and autogenic drainage, so they're both breathing techniques that we teach, and then exercise. We don't have the evidence so far to support that exercise alone is an effective enough airway clearance, but it is a benefit. And if you teach individuals to do their huff coughing with exercise, it is can form or act as a form of airway clearance. I won't go through all the manual percussion and vibration, but we tend to teach 5 different positions. We teach supine, prone, sitting forward about 45 degrees, leaning back about 45 degrees, and sideline. If you look at kind of a traditional standard approach to percussion and vibration, there are probably 12 different positions depending on which one you look at. You don't need to do all the positions. I also teach my families that even if they can get 1 or 2 of these positions in, that's better than nothing. Too often if we teach them too strict, and they have to do every one of these positions, or they have to do this exactly that way, my families just don't do it because they get frustrated. So we try to work with them and figure out the best technique, especially on a 1-year-old. Trying to get a 1-year-old to sit still to do this is really challenging. Autogenic drainage and active cycles of breathing, I'll leave up there for a minute. I'm not going to go through them right now, but they are a technique that you change your breath control to move those secretions again from those outer airways to your proximal airways to be able to clear them out and clear them out of your clear them. So what does the literature say? Maggie McGowan and Brenda Button did a Cochrane review, looked at 28 different studies, and they compared PEP to active cycles of breathing, autogenic drainage, oscillatory PEP, PRO-PEP, high frequency chest wall, BiPAP, and exercise. Findings were that all the techniques the device have a place. There did not come out that there was necessarily one technique that was better than another. Another study looked at 39 compared oscillating devices to other techniques and found no difference between the different devices. And the final one that I looked at compared autogenic drainage to other techniques, and they found that autogenic drainage was not better than any other technique. So what's the best type of airway clearance? It's the one that's done and that the patient will use and do on a regular basis. And that may vary from patient to patient. It may vary day to day. I try to give my kids a toolbox of a lot of different techniques that they can use so that if they wake up one day and they don't want to do what they normally do, they can pick something else to do. And as I talked about a little bit earlier, we try to start young and then make it as fun as we can. Nobody likes to do something every day. If you exercise, you don't love to exercise every day most of the time. We know it's good for us, but we don't always love to do it. Airway clearance is the same way. The other thing that I have found is I need to explain the why or the benefit to my patients and families, and I need to do it over and over and over again. And it's important for it to not only come from me as a physical therapist, but to come from a pulmonologist, to come from other members of the team as well, so that they know it's there. And then the other really important thing is I'm encouraging independence. By the time my kids are 7, 8, 9, 10 years old, I'm turning to them to tell me how to do their techniques and what they need to do, because ultimately they're the one that needs to be able to take over doing their airway clearance. Postural changes, they showed in the study that there was a significant difference between their study patients and their control groups in both spinal appearance and in lower extremity appearance, as well as a difference in tandem walking speed. And so why does posture matter? Every muscle of the trunk is both a respiratory and a postural muscle. Dr. Mary Mazary is a physical therapist and introduced the soda pop can model of postural control. And the idea behind that is that your diaphragm is the bottom of the pop can, vocal folds are the top of the pop can. If you think about a soda can or any kind of a can, you can stand on that can as long as everything's intact. Top hasn't been popped, anything like that, it'll hold. Our trunk is very much the same way. As soon as we start to put holes in it, we have an impaired vocal fold, we put a G-tube in it, their diaphragm isn't functioning as well. All of a sudden now we start to get truncal impairments. And then we'll start to see exercise decreases sometimes. And then it becomes, do they really have a decrease in their activity? Is it strictly just their pulmonary function, or is there something else needing or driving it, like postural changes along with the respiratory changes? So we do look at doing a regular postural screen. We treat the deficits as noted, and then again, continue that education to persons with CF and their caregivers on the importance of why we're doing it. And then exercise recommendations. This was a consensus paper that was written, and now it's been a little while ago, back in 2015, looking at what is the evidence-based guides for advising patients with CF. And what they said is habitual physical activities. Children through adolescence should have 60 minutes of physical activity or daily activity. They didn't necessarily prescribe a certain type of activity, they just need to be physically active at least an hour a day. Adults, they said 150 minutes more per week. Looking at aerobic activity, from age 7 and above through adulthood, they recommend 30 to 60 minutes of vigorous activity daily. So that would be on top of their normal daily activity. Strength training under the age of 12, we don't recognize or recommend a formal program. Bodyweight activities, have them having fun, playing, doing things. 13 and older, you can start to do some formal resistance training if it's something that they're interested in. And then other activities under the age of 12, again, we're encouraging normal motor development, including agility, balance, coordination. I encourage my families and my individuals with CF to do everything. If they have siblings, I want them doing everything they would do. If they want to play soccer, great, have them playing soccer. Whatever they want to do, encourage it, grow with it, and we'll figure out how to support it. 13 and older, we're going to continue to encourage those muscle activities and prevent or minimize adverse postural changes. Now, we are starting to see some changes in this with highly effective modulators. Our patients are becoming more active, they're wanting to do more. And so I think that's where we really need to encourage that activity. How do we encourage it? We regularly educate on the importance of exercise. We work with the patients to find what works for them. Not everybody loves to go out and run, so great, let's figure out something else for you. Help them problem solve how to fit it in their regular routine. Sometime my session with them is just sitting down and saying, hey, take me through your day. If you're struggling to get your airway clearance in, you're struggling to get exercise in, let's talk about your day. Let's walk through a normal thing, where it can be fitted in for you. And then make small goals, helps to have an accountability partner, just like for any of us. And then check in regularly with them. Ask them for specifics. If I walk into the room and say, hey, are you doing your airway clearance, or hey, are you exercising? 90% of them are going to say, yeah, sure, I'm doing that. If I come in and ask them, tell me about how you're doing your airway clearance, how often, what way you're doing it, I'll get a much better answer and usually a better, more, not that they're being dishonest, but they become more aware of what they're doing and that they may be this. Because often they don't recognize it. So putting it all together, never assume that your patients understand. They can show you, especially with some of these techniques, with your airway clearance techniques, things like that. I can think I've explained it the best way in the world, and then I have them show it to me, and I'm like, oh, we missed something there. Let's go back and look at it. Repeat, 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 and then make sure that they understand the why. The other side of this, though, is we have to respect the burden of care for these individuals and then customize that for everyone. And then partner with our individuals and the family, especially as they start to get older, so that we can have more independence and really help the kids to grow within their own awareness of taking care of themselves. Thank you.
Thank you, Dr. Dudley, for clarifying the importance and value of physical therapy in such supraprofound disease like cystic fibrosis. Indeed, it is a very integral part of the management. And now I would like to introduce an eminent professor who, in my opinion, doesn't need an introduction, but I will give him one. He is the head of the